A very warm welcome to all to the ISA online PG classes. These PG classes are held every Monday evening at 6:30 p.m. And this is a wonderful initiative by the ISA leadership in which teachers of repute from all over the country spare their valuable time and effort for the benefit of the postgraduates and the young faculty alike. But before we begin the session, as is customary, we will begin by invoking the blessings of Mata Saraswati. So,
Saraswati Namastubhyam Varade Kamarupini Vidyarambham Karishyami Siddhir Bhavatu Me Sada.
So to begin the session, may I request our honorary and very hardworking secretary, Dr. Sukhvinder Jeet Singh Bajwa sir, to please introduce this session today.
Thank you, Dr. Nishan. And it's always a privilege to get in touch with all the teachers, the students, and all the audience here on the PG online classes. They are making a mark because of the feedbacks we are receiving from various quarters, all the states, zones. And it's a wonderful, I think, experience. People, yesterday only, I think Dr. Madhuri was telling she went for as external examination. She asked a question and the person answered that question straight away. And she was stunned. How can the person know that answer? It's a difficult question because that person has already seen the PG online class. That means we are heading towards a situation where all the external examiners, their secrets are folded on these classes. So I think it's better for every PG students who are appearing for the final examination, they should be attending these classes. Coming to today's class, it's about enhanced recovery after surgery and anesthesia. The topic is very apt in the current day scenario, both theoretically, practically, clinically, professionally, because the zone, the era in which we are living, everybody wants to go home from the hospital at the earliest. Whatever the sickness, illness they are getting treated for in the hospital, they want to leave the hospital at the earliest. They want to get discharged at the earliest. Previously, we had a concept of the daycare surgery or ambulatory anesthesia. Now, with the ERAS replacing it, it's about those surgeries where the recovery time used to be a long time. Now, those surgeries, we have at least from anesthesia point of view, come to a point where we have reduced the time of rehabilitation, or if you call very invasive part, the intubation and the ventilatory part also, especially the cardiac surgery, we have reduced a lot of time, I think, for enhancing the recovery time and for a rapid discharge. But always there is a saying in Hindi, na, Jaldi kaam shaitan ka. The recovery, the early recovery can be detrimental if you are not taking the proper precautions, not sticking to the clinical basics, not sticking to the, you are having a knowledge, lack of knowledge somewhere, the barrier is there in the knowledge or skills, it can be detrimental. So it's a very balanced approach. Protocols have been set, new things have come up throughout the world, globe. We are heading towards a society where everybody will be looking towards ERAS only in the coming, I think, next decade will be time of ERAS. Whether it's a robotic surgery, whether it's, laser surgeries, whatever the advancements in the surgery occur, but ERAS will be a dominant force to reckon with in the coming decade. But considering all these pros and cons, I think the class is essential. And only 2 states have been left. One of the ISA President National, Andhra Pradesh, and one of Secretary Punjab. I think this is the first class from Punjab, and the next class should be from Andhra Pradesh. So Secretary and President have kept their states for the last classes now. Then the cycle will return again. So today, our people, reputed, very young, dynamic teachers, Dr. Sarabjit and Dr. Haramrit will be there. and they're just passed out senior resident Dr. Komal. She will be presenting the thing. I think they will be properly introduced by Dr. Nishant and Dr. Ramya. I think it's time to start. So thank you, Nishant. Back to you. You can start.
Thank you so much, sir. And yes, this is, I mean, we are extremely proud to say that this is going to be the 112th class, sir. We have a young dynamic anesthesiologist, Dr. Ramya, who will be the academic facilitator for today. Dr. Ramya, could you please take over?
Yes, sir. Good evening, everyone. My name is Dr. Ramya. I am a senior resident from Geetham Medical College, Visakhapatnam. So, coming to the faculties today, the topic is 112th class of ISA. The topic is ERAS, Enhanced Recovery of Anesthesia After Surgery. It will be presented by Dr. Komal, a senior resident, and under the moderation of Dr. Sarabjit Kaur ma'am. She is the professor and head Department of Anesthesia and Critical Care, Guru Gobind Singh Medical College, Faridkot, Punjab. Ma'am's main field of interest is pain management, difficult labor management, and regional anesthesia. She has major achievements in more than 20 years of teaching experience, fellowship in pain management from the Radia Pain Clinic, Kolkata. She's a founder and president of Farid Society of Anesthesiologists, Faridkot. She delivered and chaired lectures in various states and national CMEs and conferences. She is also a reviewer in various journals. And coming to our next moderator, ma'am, Dr. Harmanpreet Pal Kaur. Ma'am is an associate professor in the Department of Anesthesiology and Critical Care, Guru Gobind Singh Medical College, Faridkot. Ma'am's major field of interest is airway and resuscitation, and she has achieved in major achievements have done advanced course in medical education. She has more than 14 years of teaching experience. She's also a BLS and ACLS instructor, a master trainer of NELS, that is National Emergency Life Skill Course, participated as a faculty in various state and national conferences and CMEs. Ma'am has more than 50 international and national publications. Passing over to our presenter of the day today, Komal Lali. She's a senior resident and she's been partnered recently from the same medical college, Guru Gobind Singh Medical College, Faridkot, Punjab. Over to her.
Yes, ma'am.
Ramya, we'll just need to inform the audience that they'll all be muted during the course of the session.
Yes, yes,
And,
right.
yeah.
So during the class for this duration, you'll all will be muted. And any questions, you can put your questions in the chat box and it would be answered whenever possible. And yeah, over to Komal Lali.
Yes, ma'am. Good evening to all. Myself, Dr. Komal Lali, and Department of Anesthesiology from Guru Gobind Singh Medical College and Hospital, Faridkot. The topic for today's discussion is enhanced recovery after surgery. Enhanced recovery after surgery. Various terms are used for this in the early period, like enhanced recovery programs or fast-track surgery. It is an evidence-based multimodal perioperative protocols that are focused mainly on the stress reduction and the promotion of the return of the functions to the baseline. ERAS represents a paramount shift in the perioperative care, mainly in two ways. It re-examines the traditional practices that are followed and replace them with the evidence-based practices. It is comprehensive in its scope, covering all the areas of the patient's journey throughout the surgical process. It starts when the patient enters the hospital till the patient returns to the baseline function status post-operatively. Now, the concept was first initiated by Danish surgeon Professor Henrik Kallet in 1990s. He suggested that no single technique or drug regime has been shown to eliminate post-operative morbidity and mortality. Rather, he suggested that multimodal interventions should be applied that may lead to a major the reductions in the post-operative morbidity and mortality. So he went on to suggest the perioperative protocols for that. He published a trial that reported a mean post-operative hospital stay of 48 hours after elective colonic surgery. Professor Henry Callet, he did a study on the 8 patients in which he applied minimally invasive laparoscopic approach with the epidural analgesia, and he advised the patients for early oral nutrition and early mobilization post-operatively. So it was found that he was able to discharge 6 patients out of 8 on the post-operative day 2, and the 2 patients were discharged on the post-op day 3. So the patients were discharged within 48 to 72 hours after surgery. Otherwise, the length of hospital stay at that time was 5 to 10 days on an average. So in 2001, ERAS study group was formed by Professor Ken Ferran from UK and Ole Ljungqvist from Sweden. The first symposium was held in 2003. The first consensus guidelines were published in 2005. It was registered as ERAS Society in 2010 in Stockholm, Sweden. As we have discussed the initial description as fast-track surgery, the first ERAS protocols were set up for colorectal surgeries, and then it expanded to involve various other surgeries like pancreaticoduodenectomy. Protocols were set up for cystectomy, for gastric resection, for bariatric, liver, head and neck cancer surgeries, and for breast reconstruction, and many other more. Now, why we need ERAS, or what are the benefits we get from the ERAS, application of ERAS protocols? It minimizes the surgical stress response, reduces perioperative complications of the patient, reduces the length of the hospital stay, it reduces morbidity and improves patient's outcome, thereby promotes the recovery of the patient. Now, in a study published in Indian Journal of Anesthesia in 2021, a cross-sectional survey was done in India, and it was shown that by the implementation of the ERAS protocol, there is reduction in the post-operative recovery time, duration of stay, and reduction in complications post-operatively by 30 to 50%. In another recent study published in 2019 on the guidelines of the perioperative care, it was shown that by application of ERA protocols, reduction in the overall complications and length of stay was up to 50% compared with the conventional perioperative patient management. Now, ERAS is a multidisciplinary approach. Not a single person can be fully effective in the implementation of the ERAS protocols. It needs a teamwork. Nurses, dietitians, occupational therapists, physiotherapists, anesthesiologists playing an important part in this, along with the surgeons, hospital management team, and audit team is required for its implementation. Now, surgery is a major stress factor. In a trial done by Professor Henry Callet in 1997, he found that even after a successful surgery, there was unsuccessful outcome for the surgeries. So he found that the central culprit for this unsuccessful outcome was the stress response. So what the stress response does to our body after the surgery, it induces complex metabolic, hormonal, hematological, and immunological responses. The initial stimulus, it comes from cytokines, especially interleukin-6 and human necrosis factor. A delta and C nociceptive fibers, they transmit peripheral pain impulses to the CNS via spinothalamic tract. Now, various hormones are released in the body due to the stress response. The hormone levels whose are increased includes adrenocorticotropic hormone, cortisol hormone, growth hormone, insulin-like growth factor 1, antidiuretic hormone, and glucagon. They are mainly catabolic hormones. The anabolic hormones, mainly insulin, its levels are reduced or inappropriately low due to stress response. There is mobilization of the substrates in the body due to stress response by glycogenolysis, skeletal muscle breakdown, formation of acute phase proteins, or lipolysis. So overall, there is reduced ability to respond to and control hyperglycemia. There is utilization of alternative compounds, example ketone bodies, as energy substrates. The effect of major surgery on the recovery. Major surgery will produce exaggerated stress response that will lead to pain, paralytic ileus, increased cardiac demand, and respiratory complications that will ultimately lead to the delayed recovery of the patient post-operatively. Now, what are the effects of the surgical stress on the body? There will be catabolism, immunodysfunction, nausea, vomiting, post-operative ileus, impaired pulmonary function, increased cardiac demands in the body, coagulatory fibrinolytic dysfunctions will be there, cerebral dysfunction, fluid homeostasis alteration is there, sleep disturbances, and fatigue. So in ERAS, we will counter these effects by various interventions that we will study in the subsequent slides. The ERAS protocols. The ERAS protocols are set up for the pre, inter, and post-operative phase. Anesthesiologists play a unique and vital role in implementation of all the protocols in the patient's whole journey from pre-operative to post-operative phase. Now we'll go with the pre-operative components. They mainly include patient's education and counseling pre-operatively, rehabilitation of the patient, patient's optimization, smoking and alcohol cessation, pre-operative fasting and nutrition, thromboprophylaxis, pre-operative bowel preparation, and pre-anesthetic medication. Now, the first component will go with patient education and counseling. Detailed information. We need to give detailed information of the surgical and the anesthetic technique to the patient. The procedure should be properly explained to the patient in the pre-operative period. Patient should be provided with the verbal and the written information using the plain language. Not any medical terms should not be used during giving information to the patient. This will diminish patient's fear and anxiety, and that may help the patient to enhance post-operative recovery and discharge. We should encourage decision making between the patient and the family members. The family members should actively participate in the in the decision making for ERAS protocols to be implemented. Or well-designed prints, videos that can help the patients to understand the benefits with the ERAS implementations. Clear and specific instructions about the diet, mobilization, and exercises should be given. Daily targets for the patient should be set up to be applied. Prehabilitation. It is defined as a process of enhancing individual functional capacity to enable him to withstand forthcoming stress like surgery. It involves medical optimization of the comorbidities. Pre-operative physical exercises can be advised to the patient like daily walk, incentive spirometry, deep breathing exercises, or yoga, nutritional support pre-operatively, and stress or anxiety reduction. Pre-operative optimization. Pre-operative screening and optimization of the comorbidities is necessary. Assessment of the chronic medication use. If the patient is taking any of the medications for the comorbidities, we need to take a detailed history regarding them. And perioperative risk assessment using ASA grading is to be done. Now, how ERAS work? Impact of surgery on the patient's pre-existing functional status. With the pre-existing functional status in the traditional care, when there is a stress like surgery, there is a fall in the patient's functional status, and it usually takes weeks or months to recover the patient to that and come back to the pre-existing functional status. But with the ERAS protocols applied, we will take the patient's pre-existing functional status to a higher level by implementation of the protocols. So when there will be a stress like surgery, the patient will be able to recover quickly with that fall in functional status. Anemia causes an increased risk of hospital-associated infection, increased duration of hospitalization, higher probability of rehospitalization, renal impairment, and higher risk of thrombosis. So correction of the hemoglobin levels with supplements such as vitamin B12, iron, erythropoietin pre-operatively is mandatory. With the implementation of such protocols, it can help the patient, it will be helpful to obtain the best clinical results, improving the patient's recovery, reducing the rehospitalization rate, and lowering the cost. The next component is smoking and alcohol. Smoking, alcohol, drug abuse, they all are the risk factors for the post-operative complications. So ERAS guidelines recommend to stop the smoking and alcohol 4 weeks before the surgery. Smoking and alcohol cessation 6 to 8 weeks before elective surgeries can reduce the post-operative morbidity by 50%. Family physicians, they can counsel the patient regarding the smoking or alcohol cessation. For the smoking, we can prescribe smoking cessation aids can be given, supplements can be given to the patients. And with the alcohol cessation, if there is any withdrawal symptoms, vitamins or thiamines can be prescribed to the patient. Now, cure program components. There is a cure program that addresses smoking cessation with the use of the components like conversation with the patient regarding smoking cessation, understanding the patient's existing level of the addiction, replacing the patient's addiction with the nicotine supplements, and referring him to the experts for further treatment if needed. Preoperative fasting. ERAS guidelines recommend to avoid prolonged fasting and maintain the hydration of the patient, as it will lead to insulin resistance with the alpha-2 adrenergic inhibition of the pancreatic beta cells facilitated by catecholamines, or defects in the insulin receptor or intracellular signaling pathway. This will cause insulin resistance, and this has been found a major variable influencing the length of stay, poor wound healing, and increased risk of infective complications. With the prolonged fasting, there is a decreased patient's discomfort, decrease in the intravascular volume. The patient will be dehydrated, drowsiness will be there. So the guidelines recommend as preoperative carbohydrate loading should be done. The ERAS guidelines, they recommend 12.5% carbohydrate containing clear drinks. 800 ml can be taken night before the surgery and 400 ml to be taken 2 hours before the surgery. In the study, it was shown that residual gastric volume 2 hours after 400 ml of oral carbohydrate drink was found to be similar to the residual gastric volume following an overnight fast with the mean gastric volume of 21 ml. Advantages of the preoperative carbohydrate loading. It decreases the insulin resistance, increase in the carbohydrate uptake, utilization and storage, decrease in the protein breakdown and catabolism, decreases the patient discomfort, thirst, hunger, anxiety, and fatigue. It has been found that with this, there is 20% decrease in the length of the stay and 50% decrease in the insulin resistance. Preoperative nutrition. Patients should be screened for the nutritional status preoperatively, and those at the risk of undernutrition are given active nutritional support. Low BMI was a significantly better predictor of postoperative mortality risk. Perioperative nutrition care, patient can be screened on the basis of these parameters. Like in the step 1, we'll check for the BMI of the patient if it is less than 18.5 or less than 20 if the age of the patient is more than 65 years. Step 2, if the weight loss cure, we will check unplanned weight loss more than 10% in past 6 months, or the patient's intake score can be assessed. Have the patient been eating less than 50% of the normal diet in the preceding week? If answer to any of these is yes, or we'll go for the albumin levels. If they are less than 3, then preoperative nutrition clinic or dietitian intervention is required for that patient. In the perioperative quality initiative, there is 6 components for the nutrition. Pre-op and post-op nutritional screening is essential according to that, and protein is more important than the calories. Stop the feeding late pre-operatively and restart early post-operatively. Consider oral nutritional supplements for all the patients. Oral should be started before the enteral and enteral before the parenteral, and it requires teamwork. This is the thromboprophylaxis. DVT carries a significant morbidity and mortality in the patients. So use of DVT prophylaxis has reduced the incidence of perioperative DVT from 0.8% to 0% in ERAS patient population. So compression stockings and DVT pumps can be used. They can prevent venous stasis, and they are recommended for all the patients to wear. Low molecular weight heparin can be given to prevent thrombosis. It can be given OD or twice a day daily. Extended prophylaxis, that is low molecular weight heparin for 28 days, is to be given in the patients who are already taking corticosteroid therapy with comorbidities, hypercoagulable states, malignancy, or previous pelvic surgery. Now there is a Caprini risk score calculator that can help the clinician to assess the risk for the post-op venous thromboembolism and whether extended prophylaxis is needed in these patients or not. It includes two components. First one includes age and history of the patient, or the procedure and history. On the basis of these, the score will be given. If the score is 1 to 4, it comes under low risk and the prophylactically compression stocking is recommended. If the score is 5 to 8, it comes under the moderate risk. Compression stockings along with low molecular weight heparin for 7 to 10 days is recommended. With 9+ score, it is high risk, and the compression stockings along with the low molecular weight heparin 7 to 10 days with a duplex scan before stopping the low molecular weight heparin is recommended. Pre-operative bowel preparation. Routine use of mechanical bowel preparation is not recommended, as it can lead to patients' discomfort, electrolyte disturbances, there is spillage of the bowel contents, and this is also unpleasant for the patient. So it is to be given only if the anastomosis is planned in the left-sided colonic surgeries or low anterior resection of the colon. Pre-anesthetic medications. Routine use of sedatives before surgeries, they are not recommended under the ERAS guidelines. Preoperative education is preferred over the use of sedative or anxiolytic medications. If required, short-acting sedative medications should be administered. These were all our preoperative components. Now we'll discuss the intraoperative components. They are surgery related, they can be anesthesia related. Surgery related includes minimally invasive surgery, catheters or drains used. And in anesthesia related, there are antimicrobial prophylaxis, anesthesia protocols, post-op nausea vomiting prophylaxis, maintenance of normothermia in the perioperative period, and the perioperative fluid therapy. The first one is minimally invasive surgeries. Laparoscopic surgery is recommended superiorly under ERAS guidelines. It has shown that with the laparoscopic surgery, there is decreased incidence of surgical site infection. The patient will be having early ambulation. There is less of the post-operative pain in these patients, and this can result in better post-operative outcomes. If we are going for the open surgeries, then they recommend to use transverse incisions in place of the midline incisions. Antimicrobial prophylaxis. Antibiotics should be administered within 30 to 60 minutes before the skin incision, and they recommend if the repeat dose is required, that can be given to ensure adequate tissue concentration if the surgery is prolonged for more than 4 hours or the blood loss is more than 1500 ml. And chlorhexidine alcohol skin preparations before surgery have shown to reduce the surgical site infection rates by 40%. Now, anesthesia protocols. For general anesthesia, they recommend short-acting drugs to be used in the under anesthesia. Short-acting induction agents can be used like propofol. Short-acting opioids to be used, fentanyl, L-fentanyl, or remifentanil. And short-acting muscle relaxants, titrating their dose with the neuromuscular monitoring is recommended. Short-acting inhalational agents like SIBO and desflurane can be used. Total IV anesthesia with targeted controlled infusion pumps to be used in the patients with the post-op nausea vomiting. For the ventilation strategies, low tidal volume 6 to 8 ml per kg with a PEEP of 5 centimeter of water, the plateau pressure less than 16 centimeter of water with respiratory rate 8 to 10 per minute, and EtCO2 of 40 millimeter of mercury is recommended. Now, another drugs like lignocaine, recent studies are going on the lignocaine. IV can be given, as it has shown in the studies, to reduce the requirement of the perioperative opioids, and for the pain management, it has shown better results. IV bolus can be given 1.5 to 2 mg per kg, followed by infusion of 1.5 to 3 mg per kg per hour or 2 to 3 mg per minute. Analgesic, it has an analgesic effect, anti-hyperalgesic effect, and anti-inflammatory properties. It reduces the requirements for opioids and general anesthetic agents. It facilitates the early return of the bowel function and accelerates the hospital discharge. in the study shown that was published in 2020, under ERAS protocols, it recommends to use IV lidocaine as a component of opioid-sparing multimodal analgesia, particularly after the gastrointestinal surgeries. Other drugs like beta blockade therapy. Beta blockers, they blunt the sympathetic response during laryngoscopy and intubation. They have shown to reduce minimum alveolar concentration required, reduces the pain intensity and opioid consumption. And the alpha-2 agonists, they have the like dexmedetomidine and clonidine. They have shown analgesic properties. They prolong neuraxial and nerve blockades and have shown to decrease the post-operative pain. But their role in ERAS, it's still uncertain. Under the regional anesthesia techniques, nociceptive stimulus, they blunt the neuraxial blockade, they blunt the metabolic, inflammatory, and neuroendocrine stress response to surgery. We can give epidural anesthesia that can be given with the solution of the local anesthetic, or low-dose opioid can be given. It provides excellent analgesia, facilitates mobilization and physical therapy, earlier resumption of oral nutrition. It decreases the incidence and severity of the post-operative ileus and minimizes the post-op insulin resistance. With the use of spinal anesthesia, the major concern is the delayed recovery due to the persisting motor blockade. So, use of smaller doses of local anesthesia with the lipophilic intrathecal opioids is recommended. Other techniques like peripheral nerve blockades can be used, or truncal blocks can be given for the pain management of the patient. In major open abdominal and thoracic surgeries, thoracic epidural blockade can be given in surgeries like colorectal resections, gastrectomy, thoracic surgery, esophageal surgery, open aortic surgery, liver surgery, pancreatic duodenectomy, nephrectomy, or radical cystectomy. Thoracic epidural is a recommended component for the post-operative pain management under ERAS. Transverse abdominis plain block can be given in case of the open hernia repair or in case of pancreatic duodenectomy. As we have discussed, epidural analgesia under the neuraxial techniques, transverse abdominis plain block can be given, and other local anesthetic infiltrations can be used. Regional can be used alone or in combination with the general anesthesia to achieve the pain management. That will provide post-operative analgesia and will directly attenuate the post-operative stress response, help in promoting the return of the gut function. Post-op nausea vomiting prophylaxis. The most common complication following general anesthesia, it occurs in approximately 30% of all the patients. This the Apfel score is used mainly to predict the patients at risk. It includes female gender, non-smoker, history of post-op nausea vomiting previously, or post-operative opioids used. When the score is 0, 1, 2, 3, and 4, the corresponding risk for the PONV is about 10%, 20%, 40%, 60%, and 80% respectively. With the Apfel score 0 to 1, the patients come under low risk. With the score 2, they come under moderate risk, and 3 to 4 risk under high risk patients. So ERAS guidelines, they recommend for moderate risk patients, that is Apfel score 2, dexamethasone should be given at the induction and 5-HT3 receptor antagonist at the end of the surgery. In high risk patients, that is with the Apfel score 3 to 4, dexamethasone is recommended at the induction and multimodal 5-HT3 receptor antagonist or droperidol or metoclopramide at the end of the surgery. Now, next component is maintenance of normothermia perioperatively. Under general anesthesia, the core body temperature is reduced by 0.5 to 1.5 degrees Celsius in the first 30 minutes. And there is perioperative hypothermia that increases the cardiovascular morbidity, and wound infection risk is increased by increasing sympathetic discharge and inhibiting the cellular immune response. The decrease in the body core temperature, 1.9 degrees Celsius, it triples the incidence of the surgical wound infection. With the hypothermia, there is increased risk of bleeding, wound infection, and adverse cardiac events. So the recommendation is to Keep systemic warming 2 hours before and after the surgery and use active cutaneous warming. Warm IV fluids can be used. Monitoring of the temperature is recommended. Titrate the warming, prevent hypothermia, and active warming till the temperature is more than 36 degrees. The perioperative fluid therapy. The main aim is to maintain central euvolemia and avoid salt and water overload. The fluid should not be given in excess or too restricted. Excessive fluid that increases the risk of pulmonary complications, ERAS, and delays the recovery of the patient. If they are given too restricted hypovolemia, that will be associated with a higher risk of acute kidney injury. So under the goal-directed fluid therapy, it helps in optimizing perfusion, thereby improving the tissue oxygen delivery. It helps with the assessment of the volume status by the various variables, dynamic variables that are used. It is indicated in high-risk patients and surgeries with a large fluid shift. And the vasopressors are recommended for hypotensive normovolemic patients. Antral route for fluid post-operatively is to be used as early as possible. Physiological based first-line fluid replacement for goal-directed therapy. It is recommended to use crystalloids for the extracellular fluid losses for insensible perspiration or urine production. For the intravascular losses like blood loss or for further preload deficit, colloids can be used. Now comes the post-operative components. It mainly involves some multimodal analgesia techniques for the patients post-operatively and minimizing the post-operative shivering or post-operative ERAS, and the use of the catheters and drains post-operatively, and the mobilization of the patient or ambulation of the patient. Multimodal analgesia techniques. We can use various like acetaminophen can be used. IV lignocaine has a role in post-operative pain as we have already discussed. NMDA antagonists can be used. Alpha-2 agonists, the studies are still going on. Gabapentinoids can be used. NSAIDs or low-dose opioids can be used. And the regional blockade techniques, central neuraxial block, local infiltration of the local analgesics, and USC-guided field blocks can be given. Now, the ERAS guidelines, they recommend multimodal analgesia combining acetaminophen with NSAIDs unless they are contraindicated in the patients. The NSAIDs, they increase the risk of gastrointestinal and wound bleeding, decreases the kidney function, and impairs wound healing. So, selective COX-2 inhibitors can be used, but they have also shown the increased cardiovascular risk. So, studies are still needed for their precise role in enhanced recovery programs. Perioperatively, low-dose ketamine has also shown a role. It can be given bolus or IV infusion and the reduction of the pain, opioid consumption, and post-op nausea vomiting. Excessive IV opioids, they are to be avoided because of increased sedation, ERAS, respiratory complications. Although small doses of oral opioids for breakthrough pain are appropriate. Analgesic adjuncts can be given such as gabapentin or pregabalin. They have shown a beneficial opioid sparing effect post-operatively. Local or regional techniques can also be used for the post-operative pain management. Local infiltration of the wound, peripheral nerve blockade using single shot or continuous local anesthetic, interfacial plane blocks like erector spinae plane block or transverse abdominis plane block can be given. Peripheral nerve blocks can be given along with the general anesthesia or alone. Paravertebral block can be given for the pain management. Epidural analgesia and intraperitoneal instillation of local anesthetic can also be done. Now, to minimize post-operative shivering. The primary cause of post-op shivering is perioperative hypothermia. Post-operative shivering that basically increases the oxygen consumption, catecholamine release, increase in the heart rate, and increase in the pressures. That results in the cardiovascular morbidity is increased. That leads to increased length of the post-anesthesia care unit and stay. So many drugs, basically mepridine, clonidine, and tramadol can be used for the shivering, but warming strategies that are prevention we discussed in the intraoperative period, they should be applied for to maintain the temperature intraoperatively also. Now, strategies to minimize post-operative ERAS. 4 mechanisms are there mainly contributing to ERAS, that is sympathetic inhibitory reflexes, local inflammation initiated by the operative procedure, intra-op and post-operatively administered systemic opioids, and bowel edema caused by the excessive IV fluids. There is eye feed scoring system that was created. For this, it has 5 components basically based on the clinical presentation of the patient, and they are categorized as intake of the patient. Patient is tolerating oral diet, or there is limited tolerance with feeling nauseated, or E4 emesis, or examination of the patient if there is any distension with tympani or without tympani, or the duration of the symptoms. On the basis of that, we'll check for the score of the patient. If it is 0 to 2, that is normal. Standard enhanced recovery programs, including the risk-based post-op nausea vomiting prophylaxis or treatment and early feeding is recommended. For the score 3 to 5, there is post-operative gastric intolerance, antiemetics, clear fluid diet, and we can resume the normal diet as tolerated by the patient. If the score is more than equal to 6, there is post-operative gastric dysfunction. So that may need angi-tube decompression or IV fluid electrolytes management, possible nutritional support, and consider for the other etiologies in the patient. Now, for the post-operative gastric dysfunction prevention, we can prevent it using the enhanced recovery protocols to use the oral antibiotics in the elective surgeries, minimize the opioid use, maintenance of eubulimia and electrolyte balance, avoid the routine use of angi-tube insertions, employ minimally invasive surgeries whenever appropriate, and consider the use of albumin. Strategies for post-op nausea vomiting prophylaxis are recommended. Immediate return to per oral intake after the elective colorectal surgery, and coffee and gum chewing can be used to promote the GI function. If the gastric dysfunction develops, then it is treated according to its severity by angi decompression, ambulation, electrolytes repletion, or imaging studies can be done to rule out the etiology. Gut motility enhancers. There is a role of chewing gum. Chewing gum, this is a small thing, but it has been extensively studied to benefit the patient in the post-operative period. It increases the bowel activity in the early post-operative period. It has shown to decrease the time until the bowel movement begins and the first gas is released. It accelerates wound healing and increases the patient's satisfaction and shorten the hospital stay period. The catheter post-operatively, urinary catheter, it is recommended to be removed within first 24 hours in the colonic and upper rectal surgeries and 48 hours in the mid-rectal or lower rectal surgeries, and the patients at the risk of retention. The catheter removal on the post-op day 1 had lower urinary infection rate and similar recatheterization rates. So avoid the use of routine use of drains are avoided, and if they are inserted, they should be removed at the earliest. With the angi-tube insertion, routine use is not recommended under ERAS guideline. It can lead to fever, atelectasis, or pneumonia in the patients. Bowel function returns earlier in patients if angi decompression is avoided. Now, mobilization of the patient. Patient should be encouraged for early ambulation after surgery. Active mobilizing the patient within the 24 hours of surgery is recommended. Mobilizing for a minimum of 2 hours on the day of surgery, followed by 6 hours on all the subsequent hospital days. Patients who are unable to get out of the bed are instructed to do physical exercises and deep breathing exercises in their beds. We can provide the patient with the comfortable chairs, or the walker should be made available near the patient bed, so that will help the patient to ambulate early and will reduce the risk of fall of the patients. So, in conclusion, development in the ERAS that have highlighted the importance of the perioperative care. They have ERAS guidelines, they have already demonstrated the ability to achieve a reduced hospital stay in the patient's satisfaction, and reduce the rate of complications without an increase in the readmission rate. So all those team members who are involved in the perioperative care of the surgical patient, they need to be familiarized with the ERAS and its the principles. So at the end, as we have already discussed in the whole scenario, there are protocols that are applied in the pre-admission, pre-operative, intra-op, and post-operative phase that can be followed by the surgeon, anesthesiologist, and other team members like nursing staff or therapist. Thank you.
Thank you, Komal.
Thank you.
Over to the moderators if they have any questions to ask. And if not, then we can move to the next questions, case scenarios, right?
Komal, that was really nice presentation. How are we planning? We're planning to go for case scenarios now, Komal?
Yes, sir. Yes, sir.
Okay, so
Sanjit ma'am is asking to unmute. Can you unmute?
Okay.
She can.
You can unmute, yeah.
Good evening to everyone. Thank you, Dr. Komal, for your nice presentation. So now to make the topic more clearer, am I audible to everyone?
Yes, ma'am.
Yes, ma'am. Yes, ma'am. You're
Yes.
audible.
To make this topic more clearer, we would like to discuss some case scenario. So Dr. Komal, kindly share
Yes, ma'am.
your slides and case one.
Slide share. Could you please make it to the slide share view, please? Komal?
Yes, yes, sir. I'm doing.
Case one. Next slide. Next slide. Next slide.
Yes, ma'am.
No problem. Go to slideshow. ऊपर में slideshow है ना?
Yes, sir.
तो सबसे नीचे राइट साइड कॉर्नर में भी एक है ना.
Yes.
Doesn't matter. I think we can start with without even slideshow also. You can discuss.
So case number one. I am reading the case. There is a 56 years male presented in clinic, pre-anesthetic clinic with a complaint of dyspnea, constipation, pain in abdomen, and loss of appetite. There was no other clinic medical illness. Yeah.
Sorry to interrupt. The screen is stuck on case scenarios only. Can you at least select the case, like the second slide, and keep it so that everyone can look around?
Yes, ma'am. I'm trying.
Komal, or you can actually close up the whole PPT and then again restart sharing your screen again if you're stuck.
Okay, ma'am.
Yeah. Yeah.
Yeah.
Yes, ma'am.
The case scenario one is a patient, 56 years male, presented in pre-anesthesia clinic with complaint of dyspepsia, constipation, pain in abdomen, and loss of appetite. There was no other history of any medical illness in the past. On examination, patient was conscious, hemodynamically stable, and all investigation were within normal limit. On contrast, enhanced CT, large bowel loop dilated and growth present on rectosigmoid junction, and patient is planned for left-sided hemicolectomy. So Dr. Komal, which important guidelines or protocol of ERAS would you like to taken care of while managing this patient in OT?
Yes, ma'am. In this patient, we'll start with the pre-operative management. We'll in the pre-operative phase, we'll pre-operatively educate and give detailed information to the patient. The basic concern in this patient will guide him regarding the diet. Under ERAS guideline, it is recommended that we should advise the patient to take carbohydrate-rich diet, drinks 2 days, starting at least 2 days prior to the surgery. So that will make the patient to enter in the perioperative phase and the anabolic phase, so that there will be less of the perioperative morbidity in the patient. And as this is a left-sided hemicolectomy, so mechanical bowel preparation is recommended in these patients under ERAS guidelines. So the mechanical bowel preparation will be started by the surgeon team 1 day prior to the surgery, and the patient is advised to be hydrated during that and take clear fluids during the bowel preparation. And the next concern will be, ma'am, as there will be increased spillage of the bowel contents in this, so they will be at increased risk of surgical site infections or anastomosis. So these patients are recommended to take antimicrobial prophylaxis, starting at least 1 day prior to the surgeries under the guidelines.
So you have mentioned that you ask patient, you recommend or ERAS recommend carbohydrate-rich clear food to the patient. So can you tell us the options available regarding the fluids by giving some examples?
Yes, ma'am. Under ERAS guidelines, it is recommended carbohydrate 2 hours before the surgeries are also recommended. We can ask the patient to take green tea or clear without pulp juices can be advised. Apple juice or cranberry juice patient can take. Or in our scenario, we can advise the patient to take roux afza or sharbat or dal water. Patient can take those also. Or
And
commercially, commercially available, ma'am, drinks are also available for the patient to be taken before the surgery.
Yeah. Sir, we can ask for coconut water also.
Yes, ma'am.
So moving to the next case, we have all discussed the intraoperative concern about in these cases.
No,
in
ma'am.
this case. So tell me the intraoperative concern regarding the ERAS protocol.
Yes, ma'am. In the intraoperative phase, basically, analgesia will be our main concern. We can go with the thoracic epidural technique in this patient. Transverse abdominis plain block can be given to the patient with the long-acting local anesthetic can be given for the pain management. That will be beneficial for in the post-operative period also. And other multimodal IV drugs can be given for the pain management. And
IV drugs. Tell us about the some.
Yes, acetaminophen along with the NSAIDs can be recommended for the patient. IV ketamine can be used. IV lignocaine, as we discussed, infusion and bolus dose can be given for the post-operative pain management. Okay. And we will maintain perioperative fluid management also for the patient. The preloading or too excessive fluids are not advised for the gut surgeries also, as that can lead to increased risk of anastomotic leakage and bowel edema in the patients. So optimal fluid management is recommended.
Okay. And any other important guideline regarding fluid therapy?
I mean,
yeah.
Goal-directed fluid therapy can be advised to the patient. We can use in the perioperative period using dynamic measurements. If the patient is hemodynamically unstable, then we can go for the goal-directed fluid therapy.
Okay. And then moving to the post-operative management.
Yes, ma'am.
Yeah.
In the post-operative management also, ma'am, if we have thoracic epidural in situ, we can give the local anesthetics in the thoracic epidural for the pain management. We will make the patient pain-free so that will help the patient for early ambulation post-operatively. And early oral feed is to be started, is recommended. And if the patient is having any drains, that should be removed within 24 hours if when clinically appropriate by the surgeons. And for the indwelling catheters, Foley's catheters to be removed as early, but as it is a rectal resections, within 72 hours that can be removed as per the ERAS guidelines.
Okay. Thank you. Now moving to the second case.
Can you please share the second case?
Yes, ma'am.
So we have now the 75-year-old male who is diagnosed with carcinoma lower 1/3 of esophagus, and patient give the history of dyspepsia and dysphagia to solids, and he has a loss of appetite and loss of weight. He is occasional smoker since last 10 years, and however there is no other history of drug addiction. On examination, the patient is conscious and hemodynamically stable. His weight is 50 kgs and height is 168 centimeters, so with a BMI of 17.7. Other investigations are within normal limits, and he is posted for now esophagectomy. So you have a 75-year-old male, not eating since some time, weight of 50 kgs, and for esophagectomy. So what are the various elements of ERAS protocol that you can put so that we can have a better recovery in this patient?
Yes, ma'am. Ma'am, in this patient, as the patient is a smoker, we'll ask for the smoking cessation. We'll give detailed information to the patient regarding what will be are the benefits if he will not do smoke for 6 months, that sick for 4 weeks, that will benefit the patient, how that will benefit the patient post-operatively also.
Yes.
And in this patient, we'll educate the patient regarding deep breathing exercises or incentive spirometry pre-operatively, and will educate him now to how they will help in the post-operative, and he needs to continue them also in the post-operative period.
Yes.
And as the BMI of the patient is less than 80-70, it is the perioperative nutritional score. We can refer the patient to the pre-operative dietitian clinic, or proper diet management is recommended. We can ask the patient for, as the patient is not already having dysphagia to solids, not taking orally, so enteral feeding can be given pre-operatively to the patient.
So now if this patient say would have been able to eat orally, so what does ERAS protocol are there regarding to improve the nutritional status of the patient? Because when we said pre-operative, you said you can give pre-operative carbohydrate 2 hours before. You have to assess the nutritional status. And so
Yes,
how do you assess the nutritional status otherwise?
If the patient is taking orally, then he comes under low risk patient. So we can ask the patient to take orally carbohydrate or protein rich diets. Protein recommendations as under guidelines 1.5 to 2 gram per day per kg per day is recommended, and to make the calorie intake of 25 to 30 kilocalories per kg per day.
But now this patient is the one who is unable to eat. That is why he has undergone weight loss or malnourishment. So what were the options available in such patients?
Then in such patients, we'll go with the enteral feeding with the nasogastric tubes or nasojejunal tubes, and along with that, feeding jejunostomy can be done if not like it. And at the end, we can go with the parenteral therapy if then also patient's nutritional status is not recovered.
Yes, so they might take just even enteral feeding. You can just go with the one, either within 1 to 2 weeks, you can enhance the nutritional status of the patient also.
Yes.
Any other pre-operative care that you will take in such patients? So what about the timing of surgery? That is an ignored part by mostly us.
Yes, ma'am. If the patient has underwent chemotherapy, then under the guidelines, he is recommended that surgery should be done within 3 to 6 weeks after the last dose of chemotherapy. And if the patient has also underwent radiotherapy, then after 6 to 10 weeks, it is recommended.
So roughly 2 months after the last dose.
Yes.
And intraoperative, other anesthetic managements?
Ma'am, intraoperatively, analgesia is the main concern. We can go with the mid-thoracic epidural in this patient, or paravertebral block can be given in the patient, or with the multimodal IV drugs, we can go with that. And In this patient, ventilation strategies, ventilation protective strategies are to be applied low. We will ventilate the patient with low tidal volume, 6 to 8 ml per kg, with the PEEP of 2 to 5 centimeter of water, and optimal fluid management is done.
And as much as protocol that you can add from the ERAS, you would like to incorporate other low-acting or short-acting drugs and all. And in the post-operative period?
In the post-operative period, ma'am, we'll make sure that the patient is pain-free so that he'll be able to do the exercises, deep breathing and incentive spirometry early in the post-operative period, and early ambulation of the patient is can be applied. And in this case, in the esophageectomy, NG tube insertion is recommended under the ERAS guideline, but that is to be removed on the post-operative day 2 when clinically appropriate by the surgeon, but at least post-op day 2.
And again, enteral nutrition as early as
Yes, ma'am.
So I think we have covered most of the points. So just shift to the third case now.
Now, the third case, patient 55 years male, presented with osteoarthritis right knee, with complaint of pain in right knee and difficulty in weight bearing. He is social drinker and known case of hypertension. Hypertension is well controlled and he was on regular medication. There is no other surgical past history. On examination, weight and height was given, and BMI of this patient is 24.8. He is conscious and hemodynamically stable and currently posted for total knee replacement. Now, can you tell us how do ERAS protocol increase patient recovery in total knee replacement surgeries?
Yes, ma'am. In this patient, we will start with the pre-operative education and information to the patient regarding the anesthesia procedure, as this will be under neuraxial blockade. So we'll give detailed information to the patient regarding epidural catheters and catheter care in the post-operative period also, and the pain management that will help the patient. And patient is a social drinker, so we'll advise him for the cessation of the alcohol 4 weeks prior to the surgery. And he is hypertensive, so pre-operative optimization to be done. Patient is regularly taking medication, so we can continue the medication on the day of surgery also. And as these patients are having difficulty in walking or weight bearing, they are not able to do their routine daily activities as previously. So they can be at the risk of thromboembolism. So prophylaxis can be started in the pre-operative period also after consulting with the surgeon.
Or any other important ERAS protocol to prevent perioperative blood loss in these types?
Yes, ma'am. Under ERAS guidelines, it is recommended that patient can be given tranexamic acid in the intraoperative period, so that we need to transfuse, less need of blood transfusion will be there. And in these patients also, under ERAS guidelines, routine use of tourniquet is not recommended in these patients. Yes,
and also, we in this patient, our focus will be more on anti-thrombotic prophylaxis.
Prophylaxis.
Yeah.
Yes, ma'am.
Okay. Now moving to the fourth case.
Yes, ma'am.
Ma'am, there's a question regarding this. Telmisartan should be omitted on the day of surgery or not?
So yeah, it is individual basis. On individual basis, ERAS doesn't say particularly about the telmisartan.
Okay.
Your BP should be well controlled, and you have to anticipate that if the major fluid shifts are involved, then you can omit. But if the patient is going stable and you don't expect much blood loss, then you can continue with the telmisartan. ERA has nothing to comment on, especially on telmisartan.
Okay.
So now moving to the next case. So this is our another special group of patient. So that is a pregnant females. So we have a 27-year-old female with a period of gestation of 37 weeks. So she is for posted for elective LSCS, the indication being the transverse lie. So now she is with you in the for antenatal checkup with no other complaint, pregnant female with transverse lies for elective LSCS. So what does ERAS has to comment on this in case of obstetric management? What ERAS protocols can be followed, Dr. Komal?
Yes, ma'am. Ma'am, in this case, as these are pregnant patient, she will be more anxious regarding the baby and about her also. So the proper information and education of the patient, it starts when as it is elective procedure. So it starts when the patient comes to the first visit to the hospital. We should properly guide the patient regarding the anesthesia and the surgical procedure, incisions, baby care, and everything. And under ERAS guidelines, pre-operatively, sedatives are to be avoided in the pregnant patients as it will cause the delay in the skin-to-skin contact between the baby and the mother. So sedatives are to be avoided. And as we have already discussed, all the pregnant patients, they are recommended for the compression stockings for thromboprophylaxis in the patient. In these cases, and
that is a very simple thing. So all the pregnant females, they are recommended for thromboprophylaxis. Compression stockings are recommended in all the patients. So any other important and simple technique that you can use?
Antibiotic prophylaxis is recommended in these patients. The patient can be asked to take chlorhexidine alcohol soap bath a day before surgery and on the day of surgery also. And vaginal preparation can be done with the povidone iodine solution to reduce the rate of surgical site infections.
And what about intraoperative period?
I mean, the intraoperative period, regional anesthesia is preferred. So that will like maintain the birthing experience of the mother also. She will be in contact with the baby early. And preloading with the fluid is to be done in these patients, and prevention of the post-operative nausea vomiting prophylaxis with the multimodal regime is to be given. And we will prevent hypotension in the patient with the use of ephedrine or phenylephrine.
Yes. So idea is to prevent the post-op nausea vomiting, so that can be done using hydration or effective use of vasoconstrictors. And what about the post-op?
Then in the post-operative period, patient can be advised to the early removal of the catheter is advised in these patients. If the the catheter is inserted in the pre-operatively during the surgery only, then it should be removed there only in the OT at the end of the surgeries under ERAS guidelines. Even removal of the catheter after 12 hours of surgery is associated with higher risk of UTI in these patients. And the patient can be advised to take early diet within 2 hours of the surgery. Or if the surgery is, if they are planning to delay the oral feed for any reason, then at least chewing gum can be advised to the patient for as a gut motility enhancer.
Yes, so along with other things, so one thing you have mentioned is early removal of catheter.
Yes.
So that is, I think, a very revolutionary thing that you are saying, that you have to take out the catheter on table itself immediately after the post-op surgery. So that is what ERAS recommend, but that is not what traditionally we are following. So there is increased incidence of UTI in these patients. So there is no need to keep, ERAS said there is no need to keep the catheter after surgery. So you use it intraoperatively and you can just remove it at the end of a surgery. And second, as in other surgery, you have to go for early feeding.
Yes.
So thank you. So can we move to the next case, please?
Yes, ma'am.
The next case is 55-year male patient presented to emergency with chief complaint of pain abdomen, constipation, and abdominal distension. Patient didn't give history of any other medical illness in past, and on examination, patient was hemodynamically stable, and all investigation were within normal limits. On ultrasound, whole abdomen show dilated bowel loop. He is diagnosed with the intestinal obstruction, and patient is posted for emergency laboratory. So suppose you are posted in emergency, and how our ERAS protocol can easily be applied. We can be applied these ERAS protocol in emergency situation to manage this emergency laboratory.
Yes, ma'am. Ma'am, in this patient, we need to give patient family members also pre-operative, educate the patient as well as the family members regarding the perioperative morbidity of the patient, even post-operatively also. So we'll guide them regarding the operative procedure and the anesthetic procedure. In emergency cases, there should be early identification of the physiological derangements. We should start the resuscitation of the patient early, not wait till the diagnosis of the patient is made. And second, sepsis screening should be done in these patients pre-operatively. And when the patient is screened for the sepsis surviving campaign should be started. Under that, we should measure blood lactate levels are to be measured, and we should advise antibiotics. Blood cultures are to be sent before starting the antibiotics, and IV crystalloids are to be given at 30 ml per kg bolus doses. And if still the patient is not improving or the mean arterial blood pressure is less than 65 millimeter of mercury, then we can go with the addition of inotropic sport. And they have the guidelines that if the patient is sepsis with the septic shock or without the surgery, if the patient is having sepsis without the septic shock, then the source control of the surgery is to be done within 6 hours. If it is with the septic shock, then it is to be done within 3 hours. The source control of.
And what are the recommendations in emergency situation regarding the NG tube insertion?
Yes, ma'am. In the emergency patients, ERAS guidelines, they recommend the use of the NG insertion that is to be inserted in these patients. And as they are already, the patient are at risk of aspiration and there is gastric distension. So NG tube insertion is recommended in these patients.
Yeah, because of higher risk of aspiration. Which is a very life-threatening condition.
Yes, ma'am.
Any other difference regarding emergency situation regarding carbohydrate-rich fluid?
Ma'am, carbohydrate-rich fluids are not recommended in these patients. As the patient came for emergency, so we'll take the patient as an emergency.
Yeah.
And the rapid sequence induction is to be done in these patients.
And any other intraoperative protocol?
Ma'am, we should use short-acting drugs only, avoid sedative use in these patients, and will maintain the analgesia perioperatively.
Yeah, for analgesia.
And
Which technique do you want to use?
multimodal IV drugs can be given in these patients for the pain management.
Yes. Okay. So I think we have done all the cases.
Yes,
Dr.
ma'am.
I had one question with you. While we were discussing the LSCS or other, even in the protocols also, you have said that chewing gum is a very simple measure that can be used post-operatively to enhance the gut motility. So
Yes.
what has to said, how we can tell the patient, so what are the techniques, how will you tell the patient how much and for what time he has to chew that gum?
Ma'am, we can ask the patient and we will inform the patient regarding the benefits of the chewing gum, and we'll ask the patient to take one stick of chewing gum and chew it for 5 minutes, and he should take it at least 3 times a day. That.
So, and the benefits being?
The benefits being it will increase the gut motility, so there will be less chance of post-operative ileus and post-operative recovery. Gut recovery will be fast in these patients.
Yes, and even patient satisfaction would be better. Sometimes the patient say, I want to take orally, but it is not time to start. So that patient satisfaction is also improved. It is being seen after taking the chewing gum.
Yes.
Thank you.
Thank you.
Can you take the
Yes. Dr. Ramya, can we take up the
Yes, ma'am.
chat box question now?
Yes, ma'am. So there was regarding the case scenario 5, Dr. Rajni ma'am has asked for anxiolysis and analgesics are also important for this patient or not for the scenario 5.
Yes, anxiolysis and analgesics are important for this patient. For
Yes.
laparotomy patient, case
Yes,
5,
ma'am. The case 5 where the emergency laparotomy has been planned, ma'am, that case.
analgesic is important, but ERAS doesn't recommend any anxiolysis. If needed, we can use short-acting angiolysis like midazolam.
Or even the talking with the patient and the conversation with the patient would be the best angiolysis at that time instead of pharmacological angiolysis. And definitely pain management would be our main concern, even in the patient if he's undergoing the emergency laparotomy. So we have options of, as she has mentioned, IV lignocaine, IV ketamine, or even some local infiltration of the wound that can be done.
Okay, ma'am, regarding the same question, ma'am, the case scenario, is there any role of thoracic epidural in the exploratory laparotomy? This is asked by Dr. Vidya Singh Chauhan.
Yeah. So,
Komal, would you like to?
Yes, ma'am. Ma'am, if the patient is already having sepsis, then we should not go with the thoracic epidural. We will go with the general anesthesia and with the multimodal IV drug pain management only. Patient.
Okay. Ma'am, there is this one more question. What about different nerve blocks for long-term post-op analgesia in such cases?
Ma'am, for laparotomy patients?
Yeah, for laparotomy.
Ma'am, transverse
Options of nerve blocks for long-term.
Transverse abdominis plain block can be given in these patients for pain management. Erector spiny plain block, or if the patient is hemodynamically stable, we will go with the patient check for the coagulopathy. Then we can go with the blocks also in these patients. Interfacial plain blocks can be given now.
Okay. And there's this question by Dr. Samina Khatib. How long after the surgery is the patient advised to start chewing gum?
It is recommended to be started on the post-op day 1 only. Yes, in LSCS patient only, the ERAS guidelines have specified that it should be started within 2 hours. Otherwise, they have recommended to start it on the post-op day 1.
Okay. So Dr. Deepak wants to ask, is carbohydrate loading only through enteral route or it can be done through parenteral route also?
Yes, ma'am.
Is the carbohydrate loading can be done only through enteral route or it can be done through parenteral route also?
Yes, ma'am. Parenteral route it can be also given. D5% can be given. We need to give in the carbohydrate rich actually before 2 hours before the surgery, 50 gram of carbohydrate is to be given in the 400 ml drink.
Dr. Kanchan Chauhan wants to ask the ERAS protocol for diabetic patients.
Then they recommend to be used like carbohydrate rich drinks can be given in the diabetic as well as in non-diabetic patients, but strict glucose monitoring is to be done at regular intervals in these patients so that we will maintain the glucose levels at, it should be less than 180 milligram per deciliters.
Dr. Aditya Singh wants to repeat about the septic shock and without septic shock. One of the case scenarios where we are talking about shock.
Yes.
So they want to discuss that. How do you manage with the patient with the septic shock and without?
Under the guidelines, they have recommended that if the patient with the sepsis comes with the septic shock, then the source control is to be done within 3 hours. That is, surgery is to be performed within 3 hours. And if the sepsis without the septic shock is there, then it should be done within 6 hours.
Okay. Dr. Achita Patel wants to ask, in the esophagectomy with the anastomosis case scenario, will it be possible to remove the nasogastric tube on day 2?
Then that's why they have recommended earliest on the post-op day or when clinically appropriate, that the surgeon will decide if it is appropriate for them, they will remove on the post-op day 2.
Okay.
So this is, sorry, Dr. Ramya, I would like, this is where we have a traditional shift to the evidence-based medicine, because as she has rightly pointed that in traditions, so it is, so some they remove on day 5, some day 7, but we have seen surgeons removing even on a 3rd day, or they are coming closer to the day 2 against evidence-based.
So there is no particular day recommended by the ERAS.
Okay.
Can be after 2, it can be removed.
Ma'am, Dr. Rajni wants you to repeat the fluid therapy slide once again.
So Komal, can you please do it?
Yes.
And also, she has asked a question about fluid therapy where she says that a goal-directed. There was a question about goal-directed fluid therapy. So she's asking how much fluid and how long do we continue this?
Under the guidelines, ma'am, it has recommended that we should not be like overhydrate the patient or underhydrate the patient. As a overhydration has its complications, like it will in the gastric, if in the patients with the colorectal surgeries, anastomosis there will be increased chances of anastomotic leak or the post-operative ileus or pulmonary complications are also increased. And too restrictive therapy that can lead to acute kidney injury. So goal-directed fluid therapy is recommended only in high-risk patients only. But we are giving crystalloids only in these patients. If the patient is still not improving, hemodynamically unstable patient is there, not able to maintain the blood pressures or mean arterial pressures, then we will go with the goal-directed fluid therapy.
Can you repeat the last slide, please? Dr. Sneh wants to see the last slide of your presentation.
That is a conclusion slide.
Yes, sir.
She want to see the conclusion.
This one is.
Last slide was thank you or conclusion, I think.
No, sir. I guess it's done. And let's move on to the next question. Yeah, Dr. Mohan Pathak wants to know the ERAS protocol in pediatrics.
Yes, ma'am. I mean, in pediatrics also, it will go with the same pre-operative information and education, but it is more concerned to educate or inform the family members of the patient. The parents of the patient need to be guided properly, and we'll go with the pre-operative optimization of the patient. Nutritional status of the child will also be our main concern. Then intraoperatively preferred minimal invasive surgeries are to be done, and we'll use low opioid and pain management in those patients also, in pediatric patients also.
And hypothermia also. So
Hypothermia, we are making concern.
Dr. Komal, it's more easier said than done actually. Coming to pediatric ERAS, if you want to ask me honestly, it's cannot be easily practiced in any of the institutions. It has to be in a specialized pediatric center where you have all the resources, whether you have a communication skills or a clinical scenario, the equipment, the monitoring standards, the recovery areas, the stay for the parents together with the patient. There are so many things. The protocol, the discussions we are having here, the ERA guidelines, they cannot be applied uniformly to every subset of patient. Even in the pediatric patient, you have got numerous surgeries. Even for a single surgery, there can be a numerous outcomes, from very simple surgery, from even say a hernia case from a small hernia to a larger hernia. The ERAS protocols will vary. It has to be individualized. So whatever the discussions we are having here, because ERA is an evolving branch of, rehabilitation, of recovery. It's not easy that every protocol or guideline can be applied to every patient.
yes,
You have to have an individualized approach depending upon your level of skills, the equipment, the resources of your center, the manpower you have got, the protocols you have made for that particular type of surgery. You can't say that in my institution, every type of surgery can have ERAS.
yes,
You have to develop this science in a holistic manner. Go from one. Suppose you have got a pediatric center now. You will be focusing on the pediatrics. If you think that in the same time I will be having the bariatric, the geriatric, you may not be having the complete implementation of the ERAS protocols. And moreover, the ERAS protocols, they also vary from country to country.
Yes.
You are in a tropical center. You are somewhere, I think there was a question about removing the catheter after 12 hours or something, the esophageal tube or nasogastric tube removal after some time. That also depends the type of flora, whether it's the commensals or the bacteria, how they grow, in which type of atmosphere, whether you may be having the ACs in every room, but in the wards, many of the hospitals in the government setup are having wards. There is no AC. The growth of bacteria is much faster than you can get in other parts. So, and also the barrier protection, the hygiene practices we are following in our country as compared to the Western world, we can say that we are not up to that standard what they are following. The guidelines have been made by the Western world. We still have to follow the Indian guidelines considering the limitations of our resources, our manpower, our advancements. Few centers are there. They can match any standard, any setup in the world. But to holistically implement those guidelines is not possible, not feasible. Whatever is being discussed today in the class, it is a part of an evolving structure of ERAS protocols in the coming decade, which is going to be modified from center to center, from patient to patient, from age to age, gender to gender, from, I think, even the type of surgeons also.
Yes.
And ERAS guidelines have to be developed in conjunction with the societies. You can't say that anesthesia can form their own guidelines in a complete manner. No, not possible. You are talking about a nasogastric tube. When you are removing a nasogastric tube from the esophageal surgery, there are so many types of esophageal surgeries are there. Whether it's for the carcinoma, whether it's for some other surgeries, whether from a hiatus hernia, so many surgeries are there, and every surgery has got a different rehabilitation protocol. And the number of stitches, number of the surgeons and the surgeon skills, surgeon learning curve, how they want to treat their patient. As Dr. Haramrit Par was saying, or Dr. Sarvjit also saying that definitely we are getting a leftward shape coming to day 3 of the nasogastric removal of such patient. But it also depends upon the surgeon's ability to manage a complicated scenario if some complication develops in such patients. So it is a complete coordination going to be set up in the coming years. I think we are on the line. ISA will be doing these things. We will be developing the protocols of our own country. That is basically the crux of this class. Whatever was discussed, you did very beautifully in considering the current guidelines, and everybody also is asking the question. Everybody is having doubts because this is an evolving science. But I congratulate you and Dr. Sarabjit and Dr. Hamrit. You really prepared well in considering the, I think we don't follow the ERAS protocols that much, religiously in our country. But still, at least daycare surgeries we are following. So I think we will be heading towards a very good implementation of ERAS protocols which formulated to suit our set of patients, our set of centers, our set of resources and manpower. We will soon be coming with those type of protocols also. Everything said and done, it was a beautiful lecture. Now I think there are many people who will be giving their suggestions and questions will be there. This was my summary of the things entirely. Very good.
Thank you, sir. Dr. Komal, moving to another question.
Dr. Madhuri has raised hand. Dr. Ramya, Dr. Madhuri has raised hand. Let her convey something.
Yes, ma'am. Yes.
Yeah, I fully agree with sir that ERAS protocols, there are many problems in its implementation, especially in our country. And the main problem is the resistance to change. Like most of our surgeons and anesthesiologists are resistant to change. So that is one reason which is not allowing us to implement it. And one more thing is that she told in the first case scenario that was described, Dr. Komal, you said you will use intravenous ketamine intraoperatively, right? In the first case scenario.
Yes, ma'am.
That we discussed. What was that? That was a case taken for colorectal surgery.
Yes.
Hemorrhagectomy, I think, or hemicolectomy.
No,
Yes.
hemicolectomy. So you
Yes.
said you will use IV ketamine. So can you elaborate on that? How much you will use, the dose? How useful is ketamine in ERAS?
Then 0.5 mg per kg is recommended. That we can give 0.5 mg per kg of the ketamine for pain control in these patients.
That's only that much? Bolus
Yes.
doses. You mean to
Yes.
say you will give bolus doses when you feel that? When will you give the bolus dose?
In the intraoperative period only, ma'am.
No, but how will you find out that you have to give the bolus dose of ketamine? How will you know that there is an inadequate whatever, that there is a need for ketamine? How will you make out?
Yeah.
There should be some way now.
Yes, ma'am.
Then how will you make out that there is a need for
If
this
we not-
analgesic? You mean to say you want to give an analgesic dose of ketamine, right?
Yes, ma'am. If we are not giving any other analgesic drug for the post-operative pain management.
So you
also
want to
for
avoid
intra-
opioids. By
Yes,
giving
ma'am.
ketamine, you want to
Opioids.
avoid opioids.
Yes,
Okay, then
ma'am.
how about using dexmedetomidine?
Ma'am, under ERAS guidelines, they are saying that studies are still going on, so they have not specified any dose that can be used for the pain.
But even for ketamine, the role of ketamine in ERAS is also still unclear. The role of ketamine in ERAS is still unclear. And in fact, ketamine has got its own side effects, like emergence delirium, and
Yes.
what else? What else? Tachycardia, and so many other side effects, post-operative, yeah, delirium. So in ERAS, our main aim is to reduce the number of complications, basically. That is
Yes.
the main gist of ERAS, that you want to reduce the complications so that the recovery is early. So the role of ketamine is still unclear. Okay.
Okay, ma'am.
But Komal, one thing is there, if you use ketamine, actually you use at any time. The dose is 0.25 to 0.5 milligram for analgesic purpose. And this analgesia effect lasts almost 3 times longer than the anesthesia effects. No, definitely the Dr. Madhuri is right. The dexmedetomidine is there. If there are no contraindication, it's a better drug. And you can arouse the patient. Hallucinations, they occur very less with the analgesic dose of ketamine, but they are more with the anesthetic dose, provided you are not using the benzodiazepines to counteract those hallucinations. And definitely, if a patient is having hallucination, undergone a major surgery, it is sometimes difficult for that patient. You know, for surgeons also, for anesthetists also in the recovery room to have a smooth recovery for such patients. There are very good alternatives when you have been using a multimodal techniques are there. So many analgesic drugs are there. I think better to resort to good drugs rather than just avoiding the try to avoid the ketamine in this situation.
Okay.
Ketamine is a very good drug to have with you, as
Yes.
written in Miller, unless and until you don't use it. Okay, that's about ketamine.
Yeah. I have one more question, Dr. Komal. You said that somebody had asked regarding use of parenteral carbohydrate pre-operatively for
Yes.
ERAS. Is it allowed or is it only oral carbohydrate drink?
Then they have mainly recommended oral carbohydrate drinks only for pre-operative loading, carbohydrate loading.
What will happen if you give, instead of oral, IV parenteral? IV, suppose you give parenteral, that somebody suggested, no?
Yes, ma'am.
Can we give parenteral?
I think that was a post-operative, not pre-operative.
No, pre-operative only. The main aim of giving our oral carbohydrate drink is what?
When carbohydrate loading, so that the patient is in anabolic, that will decrease insulin resistance, as that is causing the patient less
Exactly.
place.
So can that not be given parenterally then?
Yes, ma'am, that can be given.
But but if you give parenterally, so what is your purpose of giving pre-operatively? Pre-operative, you want to decrease your fasting hours.
Exactly.
So
Exactly.
give IV, then So if you give carbohydrate rich, say 5%, 10% dextrose is given IV. So what are the things you can anticipate in such patients? So that is not sometimes desirable as in pre-operative period.
Exactly. Can you give IV parenteral means can you give IV glucose then? As madam said. I think that was the question. It is specifically mentioned it should be an oral carbohydrate drink, right?
Yes, ma'am. Oral carbohydrate drinks.
Yes.
Actually, the thing is that, Komal, the parenteral is basically used to give a post-operatively for the energy sources, nothing else. They have not much role because oral glucose, if you give oral dextrose, whatever the oral carbohydrate you give, it is definitely going to enhance the support system of the intestine, which is, I think, with all the gastric fluids and other things. And that is going to increase the peristaltic activity, that is to enhance the gastric motility, not gastric, rather intestinal motility. So oral carbohydrates have got much higher advantage than the parenteral carbohydrates in these type of ERAS, correct?
And also the insulin metabolomics, these are all improved with oral carbohydrates. Correct?
Increase the insulin resistance.
Yes.
Anything else, Ramya? Anything else to discuss? Unmute yourself. Ramya, unmute yourself. You are muted.
A few questions by Dr. Rajni ma'am. She wants to know, does ERAS has any hemodynamic monitoring recommendations to guide fluid therapy? And if so, which monitoring is recommended to assess for hypovolemia or low cardiac output for developing countries?
I think it's very easy to understand this concept of ERAS. It's not that ERAS means we are going to have lower standards of monitoring or the minimal standards. The way where things are going, the monitoring, whatever the surgery, the monitoring is recommended. You go with that monitoring. If the hemodynamic monitoring is recommended for a particular surgery, maybe going for a cardiac surgeries or maybe going for a major abdominal surgery where the hemodynamic monitoring is recommended, maybe patient having a severe sepsis, you go ahead with that. The ERAS is basically to shorten the recovery period. Going by the endpoints, how you decrease the endpoints to reach a stage where you can stop all these things, whether the monitorings or the drugs or the intravenous things or whatever the thing we are employing for a rehabilitation to bring the curve to the left hand side. ERAS means enhancing the recovery, not minimizing or reducing the things or abstaining the like monitoring. Monitoring has to be there. If the person is having some important surgery and monitoring is recommended, you cannot avoid, you cannot reduce monitoring standards. You have to maintain that. Whether it's coming to developing countries, I think the way we are doing the things in our as anesthesia or a surgery, we should be sticking to our system, our institutional protocols, our hospital protocols. If we try to sway away from that protocols, I think we will be in a soup rather than we may have a more chances of complications. Whatever we are doing, own resources, own manpower, the own skills, how can you reduce the time of recovery? It is, you can't just go by the Western guidelines and say, it's very difficult, I'm telling you. If you want to implement the Western guidelines in a holistic manner to our setups, every setup is a different in our country. Every setup is different. Suppose the Freed code is different, my college is different, Dr. Madhuri, Dr. Nishant is different. Every college has a different setup, every hospital has different setup. You cannot have the same protocols being followed in the same manner for the same type of surgery. You have to individualize your own setup. So many things I discussed in the beginning. So considering that, I think it has to be individualized. Learning curve will go. The knowledge will become more apparent as the time goes. The clarity of the solutions will be there as the ERAS develop in our country. It's in a developing stage, just like a developing country. It's in a developing stage. many guidelines will emerge. Many guidelines, many protocols, many advisories will emerge from our own country to make ERAS a established procedure, but not at the moment. Don't compromise with whatever is being recommended for a particular surgery and anesthesia. Don't compromise with that.
So, in Faridkot, we are using central venous pressure monitoring for giving any fluid therapy.
Obviously, in major
That's
cases.
why I think those are the institutional protocols. You have to follow those. You within the preview of those protocols, without going out of the preview of those protocols, make the recovery faster. How can you bring other factors into the play so that the recovery gets faster, enhanced, so that we can discharge the patient or we can, shift the patient to the ward. I think that is the answer to all these things. Because whatever you are feeling safe in your institution, don't compromise with the safety of the patient.
Yes, and basic monitoring will never go out of question. Heart rate, blood pressure, urine output, color of patient, vision of the patient. So again, as sir has said, complexity of surgery will decide your monitoring.
And that good teamwork is very essential for ERAS. Anesthetists cannot solely enhance the recovery. The surgical team, the nursing team, it's a very important how much practices they are doing, the surgical practices, the barrier nursing, so many things are there in the ERAS, not just one. Removing a catheter after 12 hours is okay, but suppose the patient is having a retention of urine, what will you do? Your purpose is defeated here. So you have to individualize the approach again from patient to patient. Rami, any question else? Any more questions?
So, Dr. Seema wants to know how much or how intraperitoneal installation is to be given.
That's a good question, actually.
Komal, would you like to answer?
Basically,
Installation in laparoscopic surgeries for pain management.
In laparoscopic surgeries, we can give local anesthetics 0.2% or 0.25% can be given. 20 ml can be given for the installation that will prevent visceral pain or shoulder pain or abdominal wall pain in the patient for the post-operative period, even intraoperatively if he is under neuraxial technique.
Which analgesic? Which local analgesic?
Ropivacaine can be given or bupivacaine can be given.
And even you can add adjuvants also.
Yes.
Along with port site infiltration. So that will take care of most of the pain in laparoscopic surgeries.
Yes.
Ma'am, Dr. Jayanti Mala wants to know if the fifth case where the exploratory laparotomy emergency was being done, can we do it in segmental spinal anesthesia or not?
Segmental spinal. Komal, would you like to answer? So I think as sir has rightly said, ERA is evolving. So I think segmental spinning is also evolving. So we have to see our setup, our patients, our expertise to decide whether we can go with the segmental spinal or not. So ERA has nothing to comment on segmental spinal. So our final concern is the patient safety, patient outcome. So that will depend on your expertise, your backup, your institution, your patient also. So ERA has nothing to comment on, at least. Even Western world has nothing to comment on segmental spinal.
Ma'am, there was one question. Should the child cry after extubation or he should sleep comfortable? What is your view?
What is the question, Rame?
So should the child cry after extubation, like preferably, or he should sleep comfortably?
Actually, Ramya, if a child cries on the table after extubation, the anesthesiologist become very happy.
Very happy.
It's a golden rule. If he sleeps, okay, you can monitor, but your jaan atki rehti hai.
Yes.
I think when that kid is not awake,
Yes.
the time the child cries, the first cry, I think when the mother becomes happy on the first cry of the baby. Similarly, when a child cries on the table after extubation, it gives us a lot of solace to the attending anesthesiologist. We have been doing this. We always say, "Bacha rota, hum khush hote hain."
But that doesn't mean that he will continue to cry. We have to take care of pain also. For the person who asked the question, he should be comfortable.
That's okay. So other parameters will be noted when you are extubating. Because before extubation, you will be noting other parameters of the pain, the tachycardia, whatever the fluid deficits, all the challenges you have to see that you have to manage. But
Crying is a
you
good-
are doing extubation only when everything is in control. So I think after the extubation, if the child cries, that's the best way to find that you are a good anesthesiologist, that you are safe now.
So Dr. Deepak wants to know, since there is little known about objective way of measuring pain, can we say that ketamine is analgesic effect? Is it enabling to express pain? Please elaborate.
I read that question, but I didn't understand properly what he wants to ask. I read that question also. It didn't come to me. What is the purpose of asking that question? The basic sense of that question is not clear to me even.
Yes.
Komal, is clear to you? Can you answer? I didn't get the question properly.
No, sir.
So easily you said. That's a very good way to not to answer.
Even we didn't understand the exact question, sir.
Sometimes questions actually, they always are good questions, but the meaning is not clear, then become difficult to answer properly.
Maybe the patient's inability to express pain, and how do we judge ketamine analgesic?
Dr. Pathak sir ne bola hai, now we use fentanyl, propofol, atracurium, CO. Definitely, all these new drugs, they have definitely helped. That's why the ERAS has come into play with the development of the newer gadgets, the monitoring equipment, the use of the ultrasonography, radiographic techniques, and the newer drugs, newer equipment. They have actually accelerated the ERAS practice. Definitely, no doubt about that.
Yes, we have answered all the questions, sir.
Yeah, almost everything is answered. Anybody wants to suggest something, or they can raise
Sir,
hand or they can ask.
There was Dr. Raju Vegasna, sir. He actually gave suggested one reference, which we have tagged it in the chat box already, about the new recommendations of ERAS 2021 update. And there is another one question by Dr. Ganapati. Anything about ERAS in ICU?
The same answer, I think we've given it. It's always depend upon your ICU, which ICU you're following, closed ICUs or open ICUs, what type of monitoring, what are your protocols for that ICU, shifting to the HDU, shifting to the lower ICU, what type of patients you are having, how you are really, I think ERAS in ICU will take a little longer time as compared to surgery. And ERAS in ICU, I think we are already following it, but it will not be safe to, because those are the sick patients. In surgery, the patients are not that sick, but in ICUs, almost majority of the patients are sick. So ERAS is very difficult to be really getting implemented in ICU. Because once you shift the patient and if you get the patient back, I think the purpose is defeated. You always shift the patient when you are the most comfortable, that patient will not come back to ICU again. So it's a good question, but I think we are not in a bad practice that we can establish it in ICU at the moment. Whatever the protocols are, those are for the surgery and anesthesia, not for the critical care. I think next time we will have a critical care specialist to answer these questions.
ERAS by definition is Iran's recovery after surgery. So
Yeah.
this question means surgery in the ICU.
No. I think ERAS recovery, it's a recovery of patients, maybe a post-surgical patient, maybe any medical disease patient also. So basically suffer surgery. So all the surgeries, wherever we're shifting a hemicolectomy, if Komal is getting a hemicolectomy done, definitely that patient will be shifted to ICU or HDU or surgical ICU in the beginning. So that is a part of the protocol only. So Komal, I'm preventing you, dekho. See, na, you can be helping me later on. Anybody else want to say or want to add? Or we shall, I think it's time is 8:17. But under 3 minutes, then we have to take permission from Nishant to disperse.
There is a new question by Dr. Raju Vegasna, like BIS monitoring for wakefulness. Any new monitor is around the corner which displays numbers intraoperatively.
Like BIS monitor for wakefulness, new monitor is around the corner which displays numbers intraoperatively. Yeah, definitely with the technology advancements, we are, I think we are getting many breakthroughs in the next 3 years. So many, I've personally visited one factory scan ray. What I've seen, the artificial intelligence being put into the monitors now, with the artificial intelligence and all those things coming into play in the medical technology, you will get a lot of development in the coming days. Lot of development. I think just around 15 years back, we were not having the mobiles with the video so that we can capture the whatever the parameters were on the ventilator. When a consultant is asking the what are the parameters on the ventilator, you are describing on the phone. Now you can send a video. You can send a video of the patient. So it's become easier. With advancing years, we will be having newer technology also, which will definitely help us. Definitely.
I think there are no more questions, Ramya.
No, sir.
Sir, this was a very nice presentation by Dr. Komal, and very, very confident she was. And an excellent session on ERAS by the consultant, Dr. Sarabjit and Dr. Harampreet, madam, because ERAS is very often asked question these days. Every other, even the theory question or the practicals, ERAS is being asked. So a very nice session today, sir.
Actually, the problem is that suppose somebody is appearing, a PG student is appearing from one institution. A person come from Hubli, Karnataka, ask question which is being practiced in Hubli and one's in Faridkot. The different protocols are being followed. So at that time, it becomes difficult for a PG student to answer the things exactly because ERAS is still in developing stage. But these things are going to take place. They are going to stay here. ERAS is going to stay for a long, long time and in a much modified manner in the coming years. And we will be seeing, I think, the AIMS are the leading institution. They have got all the setups. So Nishant will be coming out with some of the studies on ERAS very soon. I know today's class must have stimulated him to formulate or develop a study on ERAS. Maybe having a multi-centric, you can involve us also. So we can have a different multi-centric studies where we can have the protocols of different institutions so that we can combine on a very amalgamated type of ERAS protocol in our setup, in Indian setup. So that is, I think, a way to go forward.
Intravenous carbohydrates, sir, that is a interesting thing.
Yeah. I think, see, this classes means you ask any type of question. I ask any type of question, those are welcome. In conferences, these students go to the conferences or the senior resident go to the conferences. A senior person is giving a lecture on the stage. These students do not get any confidence of asking that question in that particular hall because they feel embarrassed. They feel, say, my question will look very silly. Log mera mazak udaenge. So these type of things are there. These classes and this clip and crisp, they have enabled people to ask anything behind the curtain. By turning off their video, they will just write a question in the chat box and that will be answered. So this is a way to go forward for these classes now, interactive sessions. This is the need of the hour. And secondly, I was mentioning again and again, you go to a conference or a CME for a day even, you spend at least more than 25,000 on that. Logistics, staying there, registration, food, and ghumna firna, so many things are there. And what you get in return, you can't sit whole day in the conference or a CME. You will just listen to 2-3 lectures, that's all. But here you devote 1.5 to 2 hours and later on the YouTube also, and you get everything on your platter, whatever you want to ask. I was very much impressed when Dr. Madhuri's googly was answered by a student at Hyderabad. She was taking examination and the person knew the answer. She was not expecting that person to know the answer, but it was because the YouTube, our ISNHQ YouTube channel, the person was all there. These people always watch the classes later on. That's a good way to go forward.
And I think even, sir, like it is very good platform from upcoming anesthesiologists. Like I was telling Komal, it is a very good opportunity for you at this stage of life that you are coming at a national platform. So that is also a very good opportunity.
It gives confidence to the youngster. These are the people who are going to take the flame forward.
Yes,
Anesthesia
sir.
is such a specialty. I think I may not be well versed in many techniques, but the newer generation, I think with the 35 to 40 years of people, what they are doing with the ultrasound blocks, I am not that much good in ultrasound blocks because those were not evolved at my time. I may do it, but those are better than me. So this is the evolving science. With every year, I think youngsters have to come to the platform. That's why it's called Ramya. to present the next time, because every state, every zone has to come up now. You can't just say only few people who are presenting or representing at every conference or CME, you see the same faces. This is a platform where every medical college from every state and zone will be getting an opportunity to express their strengths and weaknesses of that institution, which can be discussed. And I think it's a good platform. So young talent should evolve along with the seniors, under the guidance of a senior.
Yes.
You people are there, a professor and associate there, under the guidance of you, she is doing well. So I think that's the way to go forward.
Sir, after Komal, everyone wants to
What?
present. Sir, after Komal, each student wants to present seminar here, sir. So
I'm
give
telling
us
you,
more
people
opportunities.
asking me now, I have to
Yeah.
give them turns. The thing is that it is not a type of platform where you pull the leg of a student. It's a
Yeah.
discussive, interactive discussion where the teachers do come to help the students also. And that's how the science should progress. It's not about just asking a questions only. Sometimes the examiner asks only those questions which they know well.
Yeah.
But student may have studied so hard the entire subject, but examiner will ask those questions which the examiner also knows the student may not be knowing because of their experience and in life. So I think this platform gives an equal opportunity for everyone to prepare for examinations, to have the confidence, and I think interactive session with the entire nation.
Yeah.
It sometimes it's get prolonged, but on YouTube when you watch it, you get every type of answer which you are preparing. Dr. Madhuri, you want to say something? You are preparing notes again, I think. I don't write my notes, please. You want to ask something?
No, not at all. I would like to congratulate Dr. Sarvajit and the student and all the teachers, because the case scenarios which you put up were very nice. Like I have heard lectures on ERAS, but this application of ERAS, personalized medicine, depending upon the case, you have shown, and that was very impressive. Very nice presentation.
Thank you,
Thank
ma'am.
So that was the purpose actually. See, it's a Faridkot Medical College. It's in the periphery of Punjab. It's in the border state, border district. There are renowned colleges in Punjab. We give chance to them, and they have come out with such a good innovation of case scenarios and ERAs. I think that's the way to go. Every college, every hospital has a distinct identity, a distinct way of uniqueness of presenting the things. That's how it will make the classes more popular also. And Ramya, you are now next. Okay, you will be preparing the next Monday class. Okay, you can ask your teacher. So that's the way to go. You have prepared. Now today you did well. That's the way to go.
Thank you.
I think Nishant, with your permission, shall we close the class today? You are the senior moderator.
Sir, you'll have to give some certificate to us.
Sorry. Oh, extremely sorry. Extremely. Dr. Madhuri, she just laughed at me.
No,
Just-
enhanced recovery after the class. Nishant.
Yeah.
Yes, that's very important. Just give me 1 minute, not 1 minute, 30 minutes only.
30 seconds, sir.
30 seconds, sorry. देखो बोलते बोलते नहीं याद रहता कभी कभी. Is the screen visible?
Yes.
Yeah, Dr. Sarabjit, thank you so much. You being heading the department and now preparing the students so well. So we a little honor from our side, from President Sir, myself, and Dr. Venkatagiri. We always sign the certificates.
Thank you, sir.
And Dr. Haramrit, your name is being pronounced Haramrit, so I will know Punjabi name is Haramrit always.
Thank you,
So
sir.
your
So
certificate.
I'm okay with that. It could be Amrit. Some will say Har Amrit. So I'm Har Amrit. So
Yeah, it's okay. It's okay. My name is pronounced in a very different manner. I will not tell now. By everyone.
Sir, I know.
Dr. Komal, thank you so much. You did a wonderful job.
Thank you, sir. Thank you.
Dr. Ramya, you were equally good on your first appearance, your debut experience. Okay.
Thank you, sir.
And Dr. Nishant, so you are always here. Senior is one of the guys who has been instrumental in holding these classes for a long, long time. Thank you very much.
Yes, sir.
So I think it was a wonderful time today. A very good discussion. And we are like to thank all the seniors, colleagues and dear friends and keep attending these classes. They will be useful because you just have to spend only 1.5 to 2 hours and you get a lot of discussion. You can participate, you can answer on behalf of the student also. And I'm really thankful to Dr. Madhuri and Dr. Nishan because they are holding the classes. If I am not there, they are both there. So they always hold the fort. These classes have to be there every Monday. They will not be missed. Even if we are sick, even we are busy, the classes will be on time and online. So thank you, everyone. So with this, we end today's class. And we always end by saying, long live ISA and Jai Hind.